All right, so the title of my talk is Cerebrovascular Reactivity Mapping without hypercapnic. As we know, our brain requires sufficient and carefully regulated blood supply in order to function properly. Given a small volume of the brain tissue, there will always be arteries and veins. And when the brain is stimulated, the arteries will dilate to increase the blood supply. And this dilatory function is called the cerebrovascular reactivity. Previous studies have showed that this CVR is a sensitive biomarker in a number of brain diseases and conditions, such as in large vessel diseases, such as arterial stenosis and stroke, in small vessel diseases and other conditions such as TBI, brain tumor, substance abuse, and also in normal aging. Shown here is an example of CVR in intracranial stenosis. As you can see, the CVR value is largely diminished in the flow territories where the arteries are stenotic. And this is another example of small vessel disease. We found that CVR is reduced in patients with vascular cognitive impairment. And also, we found that CVR reduced significantly as we get older. So how do we measure CVR? CVR is can be measured by inducing changes in blood CO2 content and then use MRI to measure the changes in perfusion. And then once we know the input and output, we can use the general linear model to calculate CVR and get the CVR map. The most common way to introduce these blood CO2 changes are the injection of CO2 gas mixture or the injection of acetazolamide. However, these two methods require either the gas delivery system or the injection of acetazolamide. And it also requires some considerable cooperation from the subjects and may cause subjects feeling discomfort. So these kind of drawbacks made it difficult for its broader clinical applications. And shown here is one study in which we asked 55 subjects to rate how comfortable they feel during the regular MRI scan or a CO2 CVR scan. The score of 0 means the least comfortable and 10 means most comfortable. And you can see that the CO2 CVR scan is rated to be significantly less comfortable than a regular MRI scan. So our question is, can we measure CVR without gas challenges? And the answer is yes. And the conventional way to measure CVR without gas challenges is using either breath holding or hyperventilation to change blood CO2. And shown here are the example diagram of breath holding and also hyperventilation. For example, we can ask the subject to hold their breath for 20 seconds and followed by some paced breathing period. This will cause untitled CO2 change, which reflects the blood CO2 change. And similarly, the hyperventilation paradigm would also cause changes in untitled CO2. And then we can use this untitled CO2 as a regressor to map the CVR of the brain. But the breath holding or hyperventilation also require considerable cooperation from the subjects. And so it may not be suitable for some either elderly patients or patients that cannot perform these tasks, such as patients who are like very sick. And also these methods are also subject to motion and can lead to subject discomfort. So is it possible for us to map CVR using resting state scan without any gas challenges or breath holding tasks? And the answer is yes. So previous studies have shown that the global gray matter time course could be largely attributed to the untitled CO2 changes. And it is in another study, it is also shown that the low frequency global signal fluctuation can be largely reduced if we regress out the respiration variations. So because of these observations, the spontaneous changes in breathing pattern, which causes the low frequency bold signal fluctuation, they are also always considered as a nuisance signal in functional connected fMRI and are always discarded in pre-processing. However, we can utilize this low frequency global signal fluctuation to map CVR using resting state scans. One of the parameters to quantify this low frequency global signal fluctuation is the resting state fluctuation of amplitude, RSFA. It is calculated as the temporal standard deviation of the global signal time course at the low frequency range. A similar parameter is the coefficient of variance, which is the RSFA divided by the temporal mean of the global bold signal. And we have previously compared this RSFA and CO2 inhalation measured CVR and showed a significant correlation between these two parameters. And in another study by Dr. Zahachak's group, they calculated the CV coefficient of variance in a group of controls and a group of patients with chronic kidney disease. And they show that this CV is significantly higher in the patient group than in the control group. Another parameter to quantify the low frequency global fluctuation is the amplitude of low frequency fluctuation, or ALFF. It is calculated as the square root of the power spectrum across a specific low frequency band, and it can further be normalized by the power of the whole spectrum and yield the parameter called the fractional ALFF. In a study by Dr. Jing Chen's group, they compared the ALFF with the CVR obtained from CO2 inhalation, and shown here are the group averaged maps and an example individual map. From the maps, you can see these two maps showed some similarities. And if we looked at the resulted values, the ALFF also showed a significant correlation with the standard CVR measured with CO2 inhalation. And this ALFF has also been applied in clinical studies. For example, in a study with leukoasis patients, it was shown that the ALF values in this left precuneus is significantly correlated with the cognitive performance measured by the task scores in these patients. And in another study with carotid occlusion patients, the CO2 CVR, ALFF, and the fractional ALF were compared between the occlusion patients and the controls. Shown here are the group averaged maps. You can see that the CO2 CVR map in the occlusion patients is significantly lower than is lower than the controls, and this is confirmed by the quantitative analysis. However, the ALFF and the fractional ALF did not show any group difference. This may suggest that the ALFF is not as sensitive as CO2 measured CVR in detecting the CVR changes in large vessel disease. And another parameter introduced by Dr. McIntosh's group is a physiological noise matrix. It is calculated by subtracting the variance in signal attributed to the thermal noise from the total bold signal variance. They have calculated this parameter in a group of young controls, a group of elderly controls, and some small vessel disease patients. And they found that the patients group had a significantly higher physiological noise comparing to the other two groups. And shown on the right side is this scatter plot of the white matter physiological noise as a function of age and there is also a significant age effect in this parameter. So far we introduced these parameters RSFA, ALFF, and the physiological noise metric. These parameters considered only the degree of the variation, the degree of the amplitude variation of the low frequency bold signal change, but did not consider the temporal feature of the variations. So these approaches may be more prone to non-CVR related noise sources. So so if we consider the temporal feature of the bold signal change in resting state, a direct way is to use the CO2, entitled CO2 as a regressor, similar to the CO2 CVR quantification. So in this group from Dr. Jing Chen's group, they tried to use entitled CO2 as a regressor, or entitled CO2 convolved with the hemodynamic response function of CO2 as a regressor for resting state CVR mapping. They compared the measurements, the resulted maps with the standard CVR maps, and again shown here the individual maps and also the group averaged maps. Although the maps has showed some similarities across different methods, the absolute CVR values obtained from these entitled CO2 regressors did not show a significant correlation with that obtained by CO2 inhalation CVR. So we have, instead of using entitled CO2 time course as a regressor, we are trying to use the global signal fluctuation and the low frequency range as a regressor to map the CVR. And the map we obtained, because we did not use entitled CO2, the map we obtained will be a relative CVR maps. We have tried this method of using global bold signal time course as a regressor in a group of healthy subjects, and shown here are the averaged relative CVR maps from resting state scan and CO2 scan, and these two maps showed very good consistency, as also suggested by the scatter plot shown on the right. Then we tried this in a group of subjects who had consecutive resting state scans, and shown here are the example of 7 resting state CVR maps that we obtained from one subject. And we calculated the intra-class correlation of these maps, and on average, the ICC is over 0.9 across these 10 subjects, suggests a very good reproducibility of the resting state CVR map using this way. And we also tried this in patients with moyamoya disease, and shown here is an example of a patient with the left MCA stenosis. And from both the CO2 CVR map and the resting CVR map, we can obviously see the deficit in the CVR maps in the MCA flow territory. And we have also repeated this in another 7 moyamoya patients, and the 2 maps from resting state scan and CO2 CVR scan can both show similar deficit brain regions. Then we have also tried to filter this global time course signal to a narrow frequency range of 0.02 to 0.04 Hertz and calculate the CVR. And shown here are the resulted maps in a group of stroke patients. You can see that in the stroke lesion area, the CVR values seems to be lower. And then we did the quantitative analysis, and the quantitative results clearly show that the relative CVR in the stroke lesion region is significantly lower than the paralesional region, which are also lower than the control regions. So after showing, so these studies shows showed the proof of principle of this idea to use the global signal fluctuation as a regressor for relative CVR mapping. Then how can we further improve it? We know that the both signal is from multiple signal origins and is contributed by neural activity, CO2 fluctuation, cardiac and respiratory phases, bulk motion, and thermal noise. So our idea is if we could find a optimal frequency range to filter the global bold signal, then we can use the filtered bold signal to do CVR mapping, and because this filtered global signal will mainly contributed from the CO2 fluctuation. So to find this optimal frequency range, we analyzed the data from 170 healthy subjects across the lifespan, and each of the subjects had both a resting state bold scan and a CO2 inhalation CVR scan. Then we tested different frequency ranges of the global bold signal for the resting state CVR mapping and calculate the spatial correlation between the resting state CVR map and the CO2 CVR map. So shown here are the group average result. We compared a total of 120 combinations of low frequency cutoff and high frequency cutoff. And the colors of each box shows the group average correlation with CO2 CVR map. So we found that the low pass filter cutoff of 0.1164 Hertz will yield the highest spatial correlation of the relative CVR map with the CO2 CVR map, and we consider this as the optimal frequency range. We then use this frequency range to get relative CVR maps for each subject, and shown here are the example of CVR resting state CVR maps, and their corresponding CO2 CVR maps at different range of spatial correlation. And you can see when the spatial correlation is low, the resting state CVR maps has lower quality compared to the CO2 CVR. And shown here are the histogram of the correlation coefficient across all 170 subjects. And if we looked at the ratio of the subjects, if we had 96% of the subject who had a R higher than 0.4, which is this range and above, and we have 89% of subjects who had a R higher than 0.6, which is this range and above. We also tried this or tested this in a in a group of patients with moyamoya disease. We had 50 scans from these patients who had both a resting state scan and a CO2 CVR scan. And we did the same analysis, and shown here are the the histogram of the spatial correlation coefficient between the resting state CVR maps and the CO2 CVR maps in this clinical cohort. And you can see that in this clinical cohort, the success rate is lower. We had 88% of the patients who had a R larger than 0.4. And how is this R values relevant? Shown here are the examples of a patient with mild stenosis, with another patient with unilateral stenosis, and another patient with bilateral stenosis. And shown we showed the resting state CVR map and the CO2 CVR maps. And for each patient before surgery, we calculated the relative CVR within the MCA territories. And we found that when we set a threshold of R larger than 0.4 and ignore the patients who had R less than 0.4, the relative CVR values obtained from the MCA territory is significantly correlated with the stenosis grade in this MC territories. And we also like tested the sensitivity of the resting relative CVR values obtained from this resting state scan. And we compared the MC territories in patients before and after the revascularization surgery. And we found that the MC territories had CVR values significantly lower without before surgery and after surgery. And this without surgery and with surgery. And this difference can be detected by both resting state CVR and CO2 CVR. And this result suggests that this resting state CVR we obtained has similar sensitivity in detecting CVR deficit or CVR changes in clinical patients. So more recently, Dr. Lu's group is working on improving the analysis, resting state CVR analysis using deep learning methods. So in this deep learning method, they use the UNet architecture, and the input is the resting state CVR results using global signal time course as a regressor. It include both the beta 0 and beta 1 from the general linear model, and also the BAT maps, voxel-wise BAT maps obtained by shifting the global signal time course and the voxel-wise Bold signal time course. And there is also a supplementary input, which is obtained by postulating the brain into 133 ROIs, and then from then they calculate the mean signal within the mean signal of the residual time course after regress out this global signal. And they use this residual signal time course to calculate the spatial correlation across the whole brain. Then they got 133 cross correlation maps, and these cross correlation maps were put in the UNet architecture as supporting supplementary inputs. And then the output will be the deep learning calculated CVR and BAT, and they compared these two maps with the CO2 CVR and CO2 BAT to improve the network. So shown here are the example of results from healthy subjects on the top row, from moya patients on the second row, brain tumor patients on the third row, and stroke patients in the last row. And the shown here is the hypercapnic CVR. This is the hypercapnia measured BAT, and this column is the deep learning measured, deep learning calculated CVR, and this and the deep learning calculated BAT, and also here we show the general linear regression resulted CVR and BAT, which are also the input of this deep learning network. And by comparing these maps, you can clearly see that the deep learning method largely improved the CVR and BAT maps as comparing to just the direct output from the general linear model. So this resting state CVR maps can be applied to different studies or retrospectively, which has resting state scans acquired previously. But one question we always ask is, does the resolution matters? So to answer this question, we conducted another study to test the resting state CVR mapping with different spatial resolutions. So in 8 healthy subjects, we have conducted a 5-minute CO2 CVR scan, and also a 10 minutes resting state CVR scan with 2-minute resolution, 2 millimeter resolution, and another scan with 2.4 millimeter resolution, and also a scan with 3 millimeter resolution. And shown here are the resulted CVR maps we obtained from each subjects and each scans. And we looked at the accuracy of the resting state CVR mapping by comparing calculated the correlation coefficient with CO2 CVR. And shown here are the results on different resting state CVR resolutions. And we found that there's no significant group difference between the different imaging resolutions. And if we looked at the sensitivity of this resting state CVR mapping by looking at the Z values from the general linear model analysis, we found that the 3 mm resolution has significantly higher sensitivity than higher resolutions. And this is somewhat expected because larger voxels would give better sensitivity. And we also evaluated the reproducibility by dividing the 10 minutes resting state CVR scans with first 5 minutes and the last 5 minutes, and then calculated resting state CVR map from the two halves, and then calculated their spatial correlation. And we can see that there's no group difference between different spatial resolutions. So these results suggest that this method can be applied in studies with different imaging resolution and different and similar accuracy and reproducibility. And then we tried this resting state CVR mapping method in a clinical study of HIV disease. So we had a total of 160 subjects, and these subjects are divided into 4 groups: HIV positive and negative versus smoking versus non-smoker. And we found that their thalamus resting state CVR showed a significant group difference. And this thalamus relative CVR is also significantly correlated with this NIDAR CD4, which is a count of viral load. And this NIDAR CD4 has also been shown to be correlated with cognitive function. So therefore, this relative CVR may also show some association with the cognition in this HIV cohorts. And our collaborator at NYU also applied this technique in a group of patients with glaucoma. They studied normal controls, early stage glaucoma patients, and advanced stage glaucoma patients. And they found that the resting state CVR in the visual cortex and basal forebrain showed a significant group, a trend of group difference, where the patients had lower CVR values than the controls, and advanced patients has lower values than the early stage patients. And they also showed that within the visual cortex, this relative CVR is significantly correlated with the task fMRI signals, and also correlated with resting state functional connectivity fMRI Z-scores. So their results suggest that this CVR mapping detected using resting state fMRI could detect brain changes in glaucoma patients. And then they did another study in a mouse model. In this hydrogen-induced glaucoma mouse model, they obtained resting state CVR maps in both controls and glaucoma mouse. And this mouse had a right eye injection of this hydrogel to induce to elevate their intraocular pressure. And similar to the human study, they found a significant difference in relative CVR in the visual cortex and in basal forebrain. And this relative CVR in the visual cortex are significantly correlated with their intraocular pressure. And they further showed that the relative CVR in the visual cortex and in this basal forebrain are also correlated with the visual function measured by visual acuity and visual contrast in those animals. And in a recent study published this year. This group compared the CVR obtained from breath holding CVR, the resting state CVR using our methods, and also the resting state fluctuation amplitude. And shown here are the resulted maps from 2 patients with gliomas. And in this group of glioma patients, it was found that so they calculated the spatial correlation of the resting state CVR maps and RSFA map with the breath holding CVR maps, and they found that the resting state RSFA had a significantly lower correlation with the breath holding CVR as compared to our regression methods, and also they found a significant higher correlation in the whole brain than in the lesion ROIs. And there's another study by Dr. Zahachak's group that they using resting state CVR for resting stable fMRI for CVR mapping, and instead of using whole brain bold signal, they use CSF signal fluctuation as a regressor, and they compared this CSF regressor results to the breath holding results and the RSFA results after RSFA normalized to the temporal mean. And they showed that the resting state CVR mapping using CSF signal showed a similar spatial correlation with the breath holding CVR map as the CV methods. So far I talked about the CVR mapping using pure resting state bold. However, there are some limitations of CVR mapping using just a resting state bold scan, because it yields only relative CVR values when we are not using untitled CO2 as a regressor, so there's no absolute quantification. And also the success rate is not 100%, because if the subject has no fluctuation in their breath patterns during the resting state scan, we cannot get reliable CVR maps in those subjects. So how can we improve resting state CVR mapping without gas challenges? We found that we looked at the intersubject variation in the quality of resting state CVR maps, and shown here are the examples of good quality maps and subjects with poor resting state CVR maps. And we found that the standard deviation in their untitled CO2 values are significantly higher in these people with good quality than those with poor quality. So what we can do to increase the quality, increase the variation in their untitled CO2 values? One way we have been working on is the intermittent breath modulation. So in our method, the scan is still largely based on resting state scan. But once in a while, we had a 12 seconds modulation period where we have the subject follow a paced breathing for 12 seconds. We tried either 3 seconds breathe in and 3 seconds breathe out, and or 6 seconds breathing and 6 seconds breathe out. And then we had a 30 to 60 seconds jitter, like interstimulus interval until the next stimulus modulation period. Then we tried this method and compared it with the free breathing, which is the pure resting state scan, and the breath holding method, and also CO2. Excuse me. So first, we have the subject rate how comfortable they feel after each scans. And you can see that the breath holding and the CO2 scan have similar comfort level scores, which are significantly lower than the breath modulation methods and also the free breathing method. And the 6 seconds breath modulation method is has a similar comfortable level as the free breathing scan. And then we looked at this spatial correlation between CO2 CVR and these different non-gas methods. And shown here first are the resulted maps from a single subject and from the group average maps. So although the group average maps showed similar qualities across different methods, the free breathing could be worse than those other modulation scans and breath holding scans. If we look at the spatial correlation values between different non-gas methods and the CO2 CVR results, we found that the free breathing showed the lowest spatial correlation, while the 6 seconds modulation showed a similar spatial correlation with the breath holding methods. If we looked at the sensitivity of different methods, again, the free breathing showed the least sensitivity, while the breath modulation methods and breath holding showed similar values with CO2 CVR. And in terms of the quantification, the 6 seconds breath modulation methods also yield whole brain CVR values that are significantly correlated with the CO2 CVR values with a slope close to 1. And we also tried this in a group of normal elderly subjects or MCI elderly or MCI elderly, and we found that the CVR values obtained from this 6 seconds breath modulation is significantly correlated with their episodic memory scores after we account for A-beta-42, age, gender, and education, suggesting that the CVR measured with 6 seconds modulation has the sensitivity to detect cognitive function changes. Another way to improve the residency CVR mapping is to introduce the cued deep breathing. And this method is proposed by Dr. Molly Bright. So they have 2 versions of the tasks. One is some periodic modulation with cued deep breathing. And another more recent development is they have this cued breathing period happened at the beginning of a resting state scan. They repeat the cued deep breathing twice and then do a pure resting state scan after that. And shown here are the untitled CO2 time courses from a breath holding paradigm, followed by resting state scan, and a cued deep breathing followed by resting state scan. And on the right showed the resulted global bold signal, gray matter bold signal changes, which is kind of following the untitled CO2 change. And shown here are the resulted CVR maps with accounting for voxel-wise delay or without, with accounting for voxel-wise delay or without accounting for voxel-wise delay from the breath holding scan, from the cued deep breathing scan, and also the pure resting state scan, which is the later part of those scans. And it can be seen that the resting state scan in this example has lower quality and lower values than the breath holding method, while the cued deep breathing showed a very consistent pattern as the breath holding method. So in summary, I have shown that CVR methods without gas challenges could be a potential surrogate when the CVR mapping with CO2 inhalation or breath holding is not feasible. And CVR can be obtained using resting state bold data without gas inhalation. Among those resting state CVR mapping methods, the regression methods for CVR mapping may be less prone to non-CVR related noise resources. And the resting state CVR mapping could be further improved by intermittent breath modulation or cued deep breaths. And finally, I would like to thank my collaborators and also funding support. And thank you all for your attention.